and I'm going to talk about management of newly diagnosed myeloma. We'll first talk about transplant eligible patient. And in that, we'll first talk about the standard risk. It is now clear that the treatment should be triplets. In standard risk patients eligible for transplant, give VRD as the initial therapy for 3 to 4 cycles. Follow it up with transplant and then LEN maintenance. In patients who tolerate therapy well and are responding well, another alternative is to give VRD for 8 to 12 cycles and go straight to the LEN maintenance and do not do an early transplant. However, in such patients, stem cells must be collected for cryopreservation after the initial 3 to 4 cycles of VRD, and transplant must be done at first relapse. We move on to the high risk. In high risk patients, especially those who have double hit and triple hit myeloma, at the moment the ideal will be a quadruplet. That is adding Dara to VRD. Give it for 3 to 4 cycles, and this should be followed by mandatory transplant, not optional. And then the maintenance should be bortezomib based and not LEN. It could be either bortezomib every 2 weeks or a low intensity VRD in which bortezomib is given every 2 weeks, LEN is given in the dose of 15 mg, and Dex in the dose of 20 mg per week. What exactly is double hit and triple hit myeloma, and what is high risk myeloma? For this particular treatment, all intermediate and high risk myeloma have been included for the high risk. So if you have genetic events like deletion 17p, T414, T1416, 1420, gain1q, or p53 mutation, all of these should be treated as high risk myeloma. If there are 2 high risk factors, take it as double hit, and if there are 3 or more, take it as triple hit. We'll now discuss myeloma presenting with renal failure. In patients who present with acute renal failure, and if you are suspecting that this is secondary to light chain cast nephropathy, the treatment of choice will be VTD, including thalidomide, or VCD, including cyclophosphamide. This should be done in conjunction with plasma exchange or dialysis using high cutoff filter. Plasma exchange should be continued daily until the free light chain level is below 50 mg per dl, and then repeated as per need till chemotherapy becomes fully effective. We now move to patients with plasma cell leukemia and multiple extramedullary plasmacytomas. These group of patients may be best treated with chemotherapy-based protocol. You could use VDT PACE or VDT PACE-like regimens. This should be followed with autologous transplant, and then the maintenance should be with bortezomib-based therapy, which we have already defined. To fine-tune the dose and route, bortezomib must be given only by subcutaneous route and only once a week. The exception to that may be when there is an urgency of rapid disease control. This will nullify peripheral neuropathy. Dexamethasone should be 40 milligram once a week, which is called low-dose dexamethasone. Should be given once a week unless there is a need for rapid disease control. Now we move on to transplant ineligible patients. When we're talking about transplant ineligible patients, there could be a number of factors. The patient may be 70-year-old or he may be 90-year-old. He may have no comorbidities or he may have multiple comorbidities. And there may be many other issues. So the treatment intensity has to be looked into from the angle of its safety as well. Once again, it's triplets for all of them. What do I do for transplant ineligible patient? If they are standard risk, once again VRD. This time it will continue for 8 to 12 cycles because there is no transplant, and then maintain with LEN. If it's a high-risk patient, transplant ineligible, and if you cannot use Dara, you will once again continue with VRD for 8 to 12 cycles, followed by bortezomib maintenance, that is borte every 2 weeks, or the low-intensity VRD that we talked about. What's the place of Melphalan in transplant ineligible patients? So although Melphalan-based regimens have been extensively tested in past, we do not recommend them because they cause stem cell damage, leading to secondary MDS and leukemia. This risk could be significantly reduced by using cyclophosphamide, and it has been shown that this substitution is not inferior and it does not compromise efficacy. Manju just told you about endurance trial. Now, carfilzomib-based triplet in phase 2 were shown to be superior to bortezomib-based triplet. And the phase 3 data, which was presented in ASCO and EHA this year, opens your eyes that everything that is better in phase 3 does not always come out to be really a better drug. What happened with KRD, that in standard risk patient, it did not improve the response and it added to the toxicity. So just because it is a second generation, more potent PI, it does not mean that it gives you better results in a standard risk myeloma. However, that does not take away anything from carfilzomib if we are talking about high risk myeloma patients. What about frail patients? And what about patients who prefer all oral therapy? As I mentioned, that when we're talking about transplant ineligible patients, there could be somebody who is 85, 90 years old. So in frail elderly patients, one would prefer a reduced dose LEN of 15 mg and a reduced dose DEXA of 20 mg per week. For those who do not want injections at all, and if you can lay hand on ixazomib, that can be a reasonable replacement for borte, and you can use the IRD protocol. Now coming to Daratumumab. So Daratumumab based triplets. DRD is the combination to be talked about from Maya study. So newly diagnosed myeloma patients, this was an international multi-center randomized trial. Progression-free survival at 30 months was higher with DRD than RD, 70% versus 55%. MRD negativity was also superior, 24% versus 7%. Addition of Dara to RD reduced the risk of progression and death by 44% in transplant ineligible patients. Improved depth of response, including 2-fold increase in stringent CR and CR, and 3-fold improvement in MRD negativity was documented, and safety profile was almost same as that reported in relapse setting. This results into DRD as the new standard of care for newly diagnosed myeloma patient not eligible for transplant. So if you have a patient who can manage Dara, then the treatment will not be VRD, but it will be DRD. DRD therefore becomes an alternative to VRD. However, one must remember that unlike VRD, where the triplet was used for a limited duration, 8 to 12 cycle. TRD requires treatment with all the 3 drugs until progression. And that makes it very expensive in Indian setup. What about quadruplets? So Dara-based quadruplets, Alcyon study. The randomized trial showed superior progression-free survival and overall survival when Dara was added to VMP. However, contribution of Dara to the induction component could not be ascertained from this trial. And that's the publication 2 years ago of Dara with VMP. Stem cell therapy. Autologous transplant improves median overall survival in myeloma by 1 year, and therefore it's almost mandatory. Randomized trials have shown similar overall survival, whether you do it early, that is after 3 to 4 cycles of induction, or delayed, that is at the time of relapse as salvage therapy. A recent French trial is comparing early with delayed autologous transplant, where patients were treated with VRD and LEN was used for maintenance. In this, patients were randomized to receive VRD 3 cycle, followed by transplant, and then 2 cycles of VRD consolidation versus VRD 8 cycles and transplant reserved for the relapse. Both received LEN maintenance for 1 year. Significant improvement in PFS was seen as expected with early transplant, but this did not translate into overall survival. Based on these results, it is reasonable and acceptable to consider a delayed transplant in standard risk myeloma who prefer a delayed transplant because of personal reasons or logistic reasons. What about tandem transplants? Role of tandem transplants in 2020 remains unclear. In earlier randomized trials, an improvement in overall survival was seen by 2 studies, but other studies failed to show this improvement. More recent data from 2 more randomized studies were also inconclusive. In the trial conducted in Europe, an improvement in progression-free survival and overall survival was seen with Tandem in both standard and high-risk subjects. However, no survival benefit was seen in the US trial, either in standard or high-risk patients. The US trial is more likely to reflect the impact of tandem transplant in the context of modern therapy, number of these drugs which were not used in European trials. In conclusion, routine tandem transplant are not recommended at this stage. They can only be a part of clinical trials. What about allotransplants? Role of allo, including non-myeloablative, remains controversial because of conflicting results. There's high TRM of 10 to 20% and GVHD, and these are too high to be comfortable. So allotransplant remains investigational. It may be considered for a young patient who's got a high-risk myeloma and who is ready, who is willing to accept high TRM and an unproven nature of this therapy because it gives you a chance of better long-term survival. So recommendations about transplant to be summarized as auto transplant must be done for all eligible patients. In a standard risk patient, it can be delayed to first relapse provided the stem cells are harvested early in the disease. Tandem transplant is not recommended outside clinical trial, and allo remains investigational as a frontline therapy. Moving on to consolidation. Consolidation is a term used where you administer a short course of therapy made up of 2 or more drugs prior to starting long-term maintenance. The BMT-CTN trial had an arm that investigated the benefit of post-transplant consolidation therapy followed by LEN maintenance versus direct LEN maintenance. In this trial, additional cycles of VRD were given as consolidation. They did not result in significant benefits. Unlike earlier trials, the BMT-CTN trial specifically isolated the effect of consolidation, and hence this is very compelling. In short, consolidation therapy after autotransplant is not recommended, and patients should proceed to standard low-intensity maintenance therapy. Coming to the maintenance. For standard risk myeloma patients, maintenance therapy is indicated following transplant in all patients. This is standard of care. In meta-analysis of randomized trial, there was a significant improvement in PFS and OS versus placebo or no therapy. However, LEN maintenance is associated with 2 to 3-fold increase of risk of second cancer, from 2% to almost 4.5 to 5%. Patient must be informed and counseled regarding this and monitored for this. Among patients who did not undergo upfront transplant based on the SWOG trial, maintenance therapy with LEN should be considered for all standard risk myeloma patients with good performance status after 8 to 12 cycles of triplet therapy. What about high risk? Impact of LEN in patients with high risk is unclear. There was no significant overall survival. However, in a recent trial, which was not a part of meta-analysis, some benefit was shown. The recommendation will be bortezomib administered every other week, that is every 2 weeks, because it showed improved overall survival, including in patients having deletion 17p. So bortezomib-based maintenance is the preferred maintenance for high-risk patients. It could be bortezomib every 2 weeks or low-intensity VRD, which will capture the advantage of both borte and LEN. Lastly, again, patients who do not want injectable bortezomib therapy, oral ICSA could be an alternative, and it has shown benefit in a placebo-controlled randomized trial. What about the duration of maintenance therapy? Is it time-bound or is it infinity? It's not just the efficacy of LEN maintenance duration, but the side effects, which are important. So although the benefit of maintenance are established, we are not sure about the optimal duration. We do not have data which is convincing. And whenever you talk about very long-term maintenance therapy, you have to consider the cost, the toxicity, and the inconvenience. Many or probably all patients seek a drug-free interval. An ECOG trial is comparing LEN maintenance given until progression versus limited duration of 2 years. And the trials are also examining whether the duration of maintenance can be decided by the MRD results. So recommendation about maintenance therapy as of today: LEN maintenance for standard risk patient after ASCT is mandatory. LEN maintenance after 8 to 12 cycles of VRD in patients who do not receive transplant is also almost mandatory. Maintenance with borte alone or low intensity VRD will be the state of art for high risk multiple myeloma. Smoldering myeloma. What exactly is smolder? To burn slowly with smoke without flames is the Cambridge Dictionary definition of to smolder. So you have a myeloma which is not flaming, but just smoking. Smoldering myeloma is a stage which is positioned between MGUS and active myeloma. So it's a very heterogeneous group. Some of them are really myeloma, which have not manifested overtly, and others are just pre-malignant MGUS. Patients with smoldering myeloma have a risk of progression of 10% per year for the first 5 years and lesser later on. Those who were ultra high risk have been now included in the definition of active myeloma. I will not discuss this any further. So you're left with two groups, high risk and low risk. 25% per year risk of progression for the first 2 years is what happens when you've got a high risk smoldering myeloma. Now, presence of 2 or 3 risk factors is what makes the smoldering as a high risk myeloma. This is the Mayo criteria, and there are different criteria. We'll not go into that at this stage. Early studies in smoldering myeloma failed to show an advantage of preventive intervention. But these studies were not good enough because they lacked power, safe, and effective drugs. Randomized trial conducted in Spain for patients with high-risk SMM showed significant prolongation of PFS and OS with RD, len with DEXA, compared with observation. There is a recent ECOG randomized trial which has provided additional confirmation of early therapy based on len, which prolonged the time to end organ damage in patients with high-risk smoldering myeloma. Based on these two trials, patients with newly diagnosed high-risk smoldering myeloma should be considered for early intervention with either len or len-dex. There is an ongoing ECOG randomized study testing whether a myeloma like triplet, DRD, is superior to the prophylactic doublet. And also, there is a trial to look at whether these myelomas can be cured by intensive therapies like Dara, Kyprolis, Revlimid, and DEXA. So recommendation for smoldering myeloma is len or len-dex for newly diagnosed high-risk smoldering myeloma and all other patients to be observed without therapy. General management, I have no time to discuss them, but they are even more important than the specific treatment that we discussed. Infection prevention, role of vaccination, antimicrobial prophylaxis, and occasionally IV gamma globulin. Management of anemia, hypercalcemia, renal failure. Prevention and treatment of bone disease, role of bisphosphonates and denosumab. Controlling pain, including kyphoplasty, and antithrombotic prophylaxis, aspirin, warfarin, or LMWH. What was hot in EHA 25 virtual or 2020 ESCO annual meeting? So the good news and the game changers were Dara, and Dara in upfront use of myeloma treatment. So what was there was the role of Dara in newly diagnosed multiple myeloma. And the summary of these cases, because I do not have time to go into the depth of this, is update on Dara-based triplet therapy, that is Dara, Velcade, Dex, or Dara, lenalidomide, and Dex. Also, update on Dara-based quadruplet therapy, Cassiopeia, that is Dara attached to VTD, Griffin, Dara attached to VRD, and Master, Dara attached to KRD. And of course, the Master Blaster, subcutaneous route of Dara. Imagine giving Dara in 5-10 minutes versus hours. Subcutaneous Dara got its approval a couple of months ago. The other breaking news included the other monoclonal, isatuximab, for newly diagnosed high-risk myeloma in combination with KRD. We talked about carfilzomib-based therapy, endurance trial, treatment of myeloma in COVID-19 era, and MRD assessment, which is also a master blaster. MRD assessment in field of myeloma is today ripe. MRD negative status as assessed by next generation sequencing or next generation flow is the best prognostic tool, and it supersedes revised ISS or even stringent CR, etc. Additional trials are needed to determine if changes in the treatment can be made guided by MRD status. We also need additional data to determine if MRD can be used as a surrogate endpoint for the regulatory approvals. And lastly, does sustained MRD negativity means a cure? If you want to know more about MRD in myeloma and other diseases, join us after 2 days Sunday, 19th July at 11:30 a.m. for the MHG live webinar. Before I close, I bow down to Dr. Robert Kyle,